Welcome back to the deep dive. Today, we're really aiming high. We're setting out on a critical mission, achieving, let's call it surgical mastery of the nasal and paranasal sinus anatomy.
Yeah.
We're not just scratching the surface here. Forget the basic overview. We need to get into the unforgiving, millimeter-level detail, the kind of detail that elite professionals live and breathe.
Exactly.
We're pulling from specialist sources, really trying to build the ultimate operative map in our minds.
And it's a necessary mission, truly, this anatomical area. Well, it's defined by its incredible density and precision. You know, the core challenge is always translating those flat, two-dimensional CT images into a safe, three-dimensional surgical path inside the patient's head.
Right.
The margins for error, they're basically non-existent. A tiny misunderstanding of, say, a thin bony wall or an unexpected anatomical variation, that can be the difference between a successful surgery and a really severe complication, maybe even catastrophic.
Wow.
So this deep dive, it's really about understanding those potential failure points before you encounter them, anticipating them.
That absolutely sets the stakes. Okay, so to navigate this complex territory, we've broken our exploration down. Two main parts.
Makes sense.
First up, we'll lay the groundwork. The external nose, its core support system, that keystone area in the septum, and then the key surgical maneuvers in septorhinoplasty. Plus, crucially, how to manage those really dangerous vascular hazards.
Epistaxis, right?
Yes, intractable epistaxis is a major concern. We'll cover that.
Then we pivot. We go deeper into the paranasal sinuses themselves, which is, frankly, an even more complex environment. We need to understand how they develop over time, that critical hub, the ostiomeatal complex, and pinpoint those specific high-risk variations sitting right next to the brain and the optic nerve.
That's the plan. It's a lot to cover, but essential.
All right, let's start with the basics, the language, because sometimes even defining a common structure can trip people up. There's this thing called the turbinate debate. What's that about? Yeah, it sounds minor, but it causes confusion. It's really just linguistic. Pure anatomists, they prefer the term concha. They use it to describe just the bony shelf that projects out.
Okay, the bone itself.
All right. But clinically and definitely surgically, the standard term is turbinate. And when surgeons say turbinate, they mean the whole thing. The bony concha plus the soft tissue and the mucosa covering it.
Got it. So in the OR, it's always turbinate.
Always. You're dealing with the functional unit, bone, and soft tissue together.
And among these turbinates, there's one that acts like a primary guidepost once you're actually inside the nasal cavity, right?
Oh, absolutely. That's the middle turbinate. Its importance. Well, you really can't overstate it. It serves as the single most critical landmark for orientation during functional endoscopic sinus surgery, or FESS.
The main signpost.
Exactly. Its position, its stability, it tells you where the entry points are for the ethmoids, the sphenoid sinus, the frontal recess. Everything hinges off it. That's why preserving it whenever possible is vital. If you damage or remove it unnecessarily, you basically lose your internal map.
Right.
And that makes any further dissection exponentially more dangerous, not just for you, but for any surgeon who might have to operate later.
Okay, crucial landmark. Before we dive inside, though, let's step back and look at the external view, especially thinking about septorhinoplasty. What are the key things surgeons are looking at on the surface when they plan that kind of procedure?
They're doing a meticulous assessment, looking at angles, proportions. Things like the angle of rotation, you know, how much the tip turns up,
Tip rotation.
a tip projection, how far it actually sticks out from the face, the overall height of the nasal dorsum, the bridge, and critically, any existing asymmetry is one side different from the other.
And why is that surface evaluation so detailed?
Because the soft tissue envelope, the skin and underlying layers covering the bone and cartilage can be incredibly thin in some people.
Ah, I see.
Which means any irregularity, whether it was there before or, worse, created during the surgery, is going to be highly visible and palpable too. You'll feel it.
So no hiding mistakes.
Absolutely not. We're talking precision measured in fractions of a millimeter here. It has to be smooth, symmetrical.
And there's a sort of standard aesthetic ideal that's often used as a baseline, isn't there? Even if that's not the goal for every patient.
Indeed. There's a classical template, you could say. It's the division of the face into horizontal thirds: forehead, mid-face, lower face, and vertical fifths, with the eyes setting the width.
Okay.
And ideally, the nose sits right in the central third vertically and the central fifth horizontally. It defines that baseline proportion. Also, from the basal view, looking up from underneath, a well-proportioned nose typically shows the nostrils filling about the lower two-thirds of that view. It's a framework. #type tag B. The nasal skeleton and keystone support system.
All right, let's move from the surface to the underlying architecture, the scaffolding, if you like. What makes up the rigid, paired skeleton of the external nose?
Okay, so superiorly up towards the forehead, you've got the paired nasal bones.
Right.
Now, their size and shape, especially their thickness and width, they vary quite a bit between individuals. And that variability is a major factor when you're planning osteotomies, the controlled breaks needed to reshape the bony vault.
Makes sense. What's below the nasal bones?
Below them, you have the paired upper lateral cartilages. Sometimes people just call them lateral cartilages. And then forming the tip are the paired major alar cartilages, also known as the lower lateral cartilages. These give the tip its shape and definition.
Paired structures mostly. Nasal bones, upper laterals, lower laterals.
Got it.
Now, surgeons use specific terms for precise points, right? You mentioned the rhinion and the infratip break. Define those for us.
Sure. The rhinion, that's the anatomical point marking the lower end of the suture line where the two nasal bones meet in the middle. It's essentially where the bony part of the bridge transitions to the cartilaginous part.
Bone meets cartilage.
And the infratip break, that's more of a profile landmark. It's that subtle indentation or change in angle you see where the rounded lower part of the tip, the lobule, turns downwards to become the columella, the strip between the nostrils.
Ah, okay.
These terms just ensure everyone's talking about the same specific point when discussing changes, especially to the profile line. Consistency in language.
Right. Now, moving to the more dynamic support structures, there's something called the scroll area. What is that, and why is it important?
The scroll area is really interesting. It describes the way the lower edge of the upper lateral cartilages interlocks or overlaps with the upper edge of the lower lateral cartilages, the LR cartilages.
They overlap.
Yes, and they're connected there by quite a dense band of fibrous tissue. This connection, this scroll mechanism, it's a really critical dynamic support for the nasal tip. It allows some flexibility but provides essential structure.
And relevant for surgical access.
Very much so,
Yeah.
particularly in endonasal or closed rhinoplasty. Surgeons often work in or manipulate structures accessed through this scroll region between the cartilages.
Okay, that leads us nicely to the absolute central pillar of support, the keystone area. You described this as essential. What exactly is meeting or fusing there, and why is its integrity so critical?
The keystone area.
Yeah.
Yeah, essential is the right word. It's arguably the most fundamental structural point in the entire nasal dorsum. It's this junction box where four crucial elements come together and fuse.
Four elements. Okay, what are they?
You've got the perpendicular plate of the ethmoid bone. That's the upper bony part of the septum. Then you have the nasal bones, which actually fuse together and project inwards slightly as a bony spine right there.
Okay, septum and nasal bones.
Then add the upper lateral cartilages coming in from the sides. And finally, the upper edge of the quadrilateral cartilaginous septum itself. All four articulate and fuse in this zone.
Wow, okay. That sounds complex. And why is it non-negotiable to preserve it?
Because this fusion provides the primary essential support for the entire mid-portion of the nasal bridge, the dorsum. If you destabilize this keystone, say, during an aggressive dorsal reduction where you take down too much bone or cartilage right there, you lose the support for the upper lateral cartilages.
And the consequence?
Twofold and both bad. First, the upper laterals can collapse inwards, leading to internal nasal valve collapse. That means difficulty breathing.
Functional problem.
Big functional problem. And second, you get an aesthetic collapse. The bridge looks pinched or caved in. It's why maintaining the integrity of that keystone fusion is paramount in rhinoplasty.
That central keystone structure naturally leads us into the septum, doesn't it?
Yeah.
The wall down the middle of the nose. What are the main parts that make up this partition?
Right, the septum. It's a composite structure, part bone, part cartilage. If you think about it from back to front. Posteriorly, you have a bone called the vomer.
Vomer, okay.
Then superiorly, so backing up, is the perpendicular plate of the ethmoid bone. That same structure we just mentioned meeting at the keystone.
Right, connecting there.
And then anteriorly, making up the front part that gives the nose flexibility near the tip, is the large quadrilateral cartilaginous septum, the cartilage part.
So vomer, perpendicular plate, and cartilage. And what holds this whole wall stable?
Stability comes from its attachments. It slots into grooves and attaches to the anterior nasal spine. That's a little bony projection from the maxillary crest right at the bottom front. It also attaches along the floor to the maxilla and palatine bones, and inferiorly it connects to the vomer. These attachments anchor it.
And deviations, bends, or spurs in this structure are super common, right? A major cause of blocked noses.
Extremely common. Deviations in the cartilage or the bone or bony spurs projecting off it are probably the most frequent structural cause of nasal obstruction that we see.
But when we think about fixing these deviations, especially in younger people, kids or teenagers, there's a huge red flag, a critical warning. What's that about?
Absolutely crucial point. The cartilaginous part of the septum, that quadrilateral cartilage, isn't just a partition. It functions as a major growth center for the developing midface. The whole central part of the face relies on its growth.
A growth center. Wow.
Yes, and we see significant, quite rapid growth happening roughly between the ages of 8 and 12. That growth generally finishes around 15 or 16 years old, maybe a bit later in boys.
So what's the surgical implication? It sounds serious.
It is serious. The implication is that any surgery on the septum in a child or adolescent must be either delayed until growth is complete, or if it's absolutely unavoidable for severe obstruction, it has to be incredibly conservative.
Why? What happens if you're too aggressive?
If you resect too much of that growing cartilage, you risk permanently stunting the growth of the midface. It can lead to midfacial hypoplasia, where the central face doesn't grow properly, or even a collapsed, underdeveloped appearance. So the rule is, hands off the pediatric septum unless absolutely necessary, and even then, be minimal.
Okay, so assuming growth is complete, or the need is urgent, if that structural foundation, the septum or the external nose, is compromised, maybe functionally, maybe aesthetically, maybe post-trauma, the procedure is often septorhinoplasty. Let's talk approaches and, really importantly, the surgical plane.
Right. Septorhinoplasty addresses both the septum, septo, and the external nose, rhinoplasty. There are two main ways to get in. The endonasal or closed approach uses incisions only inside the nostrils, inside the vestibule.
No external scar.
Correct. It limits visible scarring, which is appealing, but sometimes it restricts how well you can see and access all the structures, especially the tip.
And the alternative?
The open approach. This involves a small incision, usually a stepped or inverted V shape, across the columella that's stripped between the nostrils.
Okay, a small external cut.
Yes, but it allows the surgeon to lift the entire skin and soft tissue envelope right off the underlying bone and cartilage. This gives much better exposure, direct visualization of everything, the bones, the septum, all the tip cartilages. It's often preferred for more complex reconstructions or revisions.
And whichever way you go in, endonasal or open, what's the specific tissue plane you want to be operating in when lifting that soft tissue, and why that plane?
The critical surgical plane for elevation is deep to the SMAS. That's the superficial musculo-eponeurotic system. It's a layer that contains the small nasal muscles, vessels, and nerves.
Okay, so underneath that layer.
Exactly. You want to elevate in the plane just above the perichondrium, which is the lining of the cartilage, or the periosteum, the lining of the bone. Staying deep to the SMAS does a few important things.
Like what?
It preserves the delicate muscles, minimizes unnecessary scarring within the soft tissues, and crucially, it protects the overlying blood supply and lymphatic drainage. This leads to better healing, less swelling, and a more predictable outcome. It's the clean plane.
Makes sense. Now, once you're in that plane, how do you actually adjust the structures? How are the bones and cartilages reshaped or moved?
Okay, for the bony part, the dorsum, we typically use osteotomies. These are very precise, controlled surgical cuts or breaks in the nasal bones. We use specialized instruments like fine saws or osteotomes to mobilize them.
And you mentioned the nasal bones vary.
Yes, their thickness and width directly influence how easy or difficult these osteotomies are. If you want to reduce the height of the dorsum, a hump reduction, you remove segments of the nasal bones, maybe the upper lateral cartilages, and sometimes the top edge of the septum.
And if the dorsum is too low, augmentation.
Right. For augmentation, you need to add material. That could be cartilage grafts, bone grafts, or sometimes synthetic implants placed under the soft tissue envelope to build up the height.
What about adjusting the tip? That seems intricate.
Tip work is very meticulous. It usually involves reshaping the major ulnar cartilages, the lower laterals. You might use precise sutures to change their shape or position, selectively trim or weaken parts of the cartilage, or add small cartilage grafts for support or definition. It's all about controlling the shape and projection of those tip cartilages.
You mentioned grafts. Let's focus on one specific, really important type, the spreader graft. What exactly does it do, and how does it work?
Spreader grafts are workhorse tools, truly indispensable in modern rhinoplasty. They're typically narrow strips of cartilage, Ideally, you use cartilage harvested from the patient's own septum if available, because it's strong and integrates well.
Okay, strips of cartilage, where do they go?
They are placed and secured, often with fine stitches, between the upper edge of the nasal septum and the upper lateral cartilage on one or both sides, right in that internal angle.
And what's the purpose of putting them there?
They serve a critical dual function. First, functionally, they push the upper lateral cartilage outwards, laterally. This directly opens up the internal nasal valve angle, the narrowest part of the airway just inside the nose, so it improves breathing, relieves obstruction.
Okay, airway improvement. What's the second function?
Aesthetically, they help rebuild or support the middle part of the nasal bridge. They prevent the upper lateral cartilages from collapsing inwards after surgery, which can cause an inverted V deformity, a visible shadow, or indentation. So they maintain a smooth dorsal aesthetic line and improve the airway. Hugely important.
Got it, dual benefit. Now, the flip side of structural work, especially on the septum, is the major warning. The saddle nose deformity. What causes that?
Saddle nose is the classic complication of overaggressive septal surgery. You need to correct deviations, yes, but you must preserve enough cartilage to maintain structural support. Specifically, you need an L strut, a strong strip of cartilage along the dorsum top, and the columella front.
The L strut, okay.
If you resect too much cartilage and violate that L strut, you lose the fundamental support for the bridge and tip. The middle part of the nose then collapses downwards, creating that characteristic saddle depression on the profile. The tip might also droop, which we call ptosis.
So it's a direct result of taking out too much support.
Exactly. It's the visual evidence that the structural safety margin was exceeded during septal resection. A devastating complication, functionally and aesthetically. #EE. Management of intractable epistaxis and vascular hazards.
Okay, we've talked structure. Now let's shift to a major complication. Bleeding. Specifically, severe intractable epistaxis nosebleeds that just won't stop with packing or cautery. When conservative measures fail, surgical ligation deep inside the nose might be needed. Where does that severe bleeding usually come from?
The vast majority, probably 80–90%, of really severe posterior nosebleeds that require surgery originate from the terminal branches of the sphenopalatine artery, SPA. There are exceptions, especially in trauma, involving the front of the nose, where the anterior ethmoidal artery might be the culprit, but usually it's the SPA territory.
And the procedure to control it is typically endoscopic.
Yes, endoscopic ligation of the SPA is the standard approach now. It involves making a fairly wide incision in the mucosa on the lateral nasal wall, just in front of the back end of the middle turbinate. Then you elevate that mucosa carefully in a superiosteal plane right down on the bone to find the artery bundle as it exits its foramen.
Sounds challenging, especially if it's bleeding heavily. How does the surgeon reliably find the artery in that situation? Is there a specific landmark?
There is a very reliable landmark, thankfully. It's called the crista ethmoidalis. This is a small, vertical, bony ridge on the palatine bone, just anterior to where the SPA emerges from the sphenopalatine foramen.
Crista ethmoidalis.
As the artery comes out of that foramen, moving from the pterygopalatine fossa, a space behind the maxilla, into the nasal cavity proper, it's almost always found just posterior to or slightly behind this crista. It's the surgical beacon you look for to locate the vessel.
Found the beacon. But you mentioned a crucial detail that makes this more than just clamping one vessel.
Right. The critical detail is that the SPA often doesn't exit the foramen as a single trunk. Very commonly, it splits into several large branches immediately upon exiting, or even within the foramen itself. Usually a posterior septal branch heading medially and posterolateral branches heading out.
So multiple targets.
Exactly. You can't just clip or cauterize the first vessel you see. You have to meticulously identify every single branch, sometimes 2, 3, or even more, and ligate each one individually, usually with bipolar diathermy or surgical clips. If you miss even one significant branch, the bleeding will likely continue or recur. Complete identification is key.
That complexity makes sense when you consider the nose's blood supply. It's not just one source, is it? It's a dual system.
That's absolutely right. The dual supply is what makes nasal vascular issues potentially so complex and sometimes dangerous. You have contributions from both the external carotid artery system and the internal carotid artery system.
Okay, break that down. Which parts come from where?
The bulk of the supply, especially to the turbinates, the meatuses, the spaces under the turbinates, and the posterior and lower parts of the septum, comes from the external carotid circulation. primarily via branches of the maxillary artery, the sphenopalatine being the main one, but also the greater palatine and some alveolar branches. And also the facial artery contributes via the superior labial artery anteriorly.
So external carotid handles most of the lower posterior nose. What about the internal carotid supply? Where does that go and why is it more dangerous?
The internal carotid supply comes via the ophthalmic artery, which is primarily supplying the eye and orbit. Branches from the ophthalmic artery, specifically the anterior and posterior ethmoidal arteries, enter the nose from the orbit high up. They supply the upper part of the septum, the ethmoidal sinuses, and the frontal sinus.
And that connection to the internal carotid circulation leads us directly to extreme hazard number 1, the anterior ethmoidal artery, AEA. Why is damaging this specific vessel so uniquely dangerous, potentially even causing blindness?
The AEA is uniquely hazardous for two main reasons, both related to its origin from the internal carotid via the ophthalmic artery. First, because its internal carotid supply, bleeding from the AEA cannot be controlled by ligating the external carotid artery in the neck, nor by standard embolization procedures targeting the external system. The source is upstream, closer to the brain.
Okay, harder to control the source. What's the second reason?
The second reason is its path. The AEA runs from the orbit into the nose through the anterior ethmoidal foramen, then crosses the roof of the ethmoid sinuses, often in a bony canal, but sometimes just suspended in the mucosa, before descending into the nasal cavity. If this artery is damaged or cut, especially near the skull base, the damaged end can retract back into the orbit, behind the orbital septum, which acts like a diaphragm. If it retracts into the orbit and continues to bleed, it creates a rapidly expanding orbital hematoma, a bleed in a closed space.
Pressure buildup in the eye socket.
Exactly. The pressure inside the orbit skyrockets, compressing the optic nerve. This can cause irreversible visual loss within minutes to hours if that pressure isn't relieved immediately. It's a true surgical emergency.
And what is that immediate, non-negotiable emergency treatment if you suspect an orbital hematoma compressing the optic nerve?
If there are signs of visual loss, decreased pupil reactivity, or significant proptosis, bulging of the eye, you perform an emergency lateral canthotomy and inferior cantholysis. Basically, you make a cut at the outer corner of the eye and snip the lower eyelid tendon.
Releasing the pressure.
Precisely. It opens up that closed space, allows the blood to escape, drops the intraorbital pressure, and hopefully decompresses the optic nerve in time to save vision. Time is absolutely critical.
Okay, a terrifying complication. Now, for extreme hazard number 2, which seems almost counterintuitive, vasoconstrictor toxicity, causing blindness from a simple nasal injection. How can that happen?
It seems counterintuitive, but it highlights the incredibly rich and interconnected vascular network. When vasoconstrictors like lidocaine mixed with epinephrine, adrenaline, are injected into the nasal septum or turbinates, often done to reduce bleeding during surgery.
Yeah, standard technique.
A standard technique, but it carries this risk. The nasal mucosa has a very dense submucosal venous plexus, a network of veins. This plexus drains directly backwards into the ophthalmic veins, which then connect intracranially to the cavernous sinus.
Okay, venous connection to the orbit and brain.
And critically, there are also numerous tiny arteriovenous anastomoses, direct connections between small arteries and veins. If the vasoconstrictor solution is injected too forcefully or into a vessel, it can be forced backwards through these venous plexuses or shunted through the arteriovenous connections directly into the ophthalmic arterial circulation.
Gets into the artery supplying the eye.
Exactly. Once the potent vasoconstrictor hits the central retinal artery or other arteries supplying the optic nerve, it can cause intense spasm or thrombosis, clotting, shutting off blood supply to the retina. This leads to sudden, profound, and often permanent blindness. It's a stark reminder of how intimately the nasal vasculature is linked to the orbital and intracranial circulation.
All right, let's move deeper now, away from the nose itself and into the surrounding air-filled cavities within the skull, the paranasal sinuses.
Yeah.
Before we talk anatomy, it's helpful to recall how these skull bones form, right? Endochondral versus intramembranous ossification.
Yes, that's a good starting point because it relates to their development. The ethmoid bone complex and the sphenoid bone, which form parts of the skull base and house sinuses, develop from cartilage precursors. That's endochondral ossification, part of the primitive nasal capsule.
Okay, ethmoid and sphenoid from cartilage.
Whereas at the maxillae, upper jaw bones, housing the maxillary sinuses, and the frontal bone develop directly within membranes. That's intramembranous ossification. This difference in origin contributes to their quite different developmental timelines.
So which sinuses are actually starting to form or pneumatize, meaning become air-filled right around birth?
The ethmoidal air cells are essentially present and begin pneumatizing right from birth. They're the earliest. The maxillary sinuses are also considered early developers. Pneumatization is seen in maybe 45% of newborns within the first month.
Almost half.
Yeah, and it becomes pretty much universal by 7 to 12 months. By age 4, the maxillary sinus is usually well developed enough that it's surgically relevant in children.
So ethmoids and maxillary are the early birds. Which ones develop later, sometimes influencing when surgery might be considered?
The sphenoid sinus, located deep in the center of the skull base, starts its pneumatization towards the end of the first year of life. But its expansion is slow. It doesn't really reach its full adult size until the early to mid-teens.
Okay, sphenoid is a teenager. What about the frontal sinus?
The frontal sinus in the forehead bone is the last to develop and also the most variable. It begins as just a small outpouching from the anterior ethmoids from the area called the frontal recess or infundibulum, usually around age 2.
It's our slate.
Right. But its real expansion doesn't kick in until after age 5, and then it accelerates. It's typically considered fully pneumatized and reaches its adult size by around 14 or 15 years old.
Given that variability, especially with the frontal sinus, what's the absolute must-do check before any surgery involving it?
Because the frontal sinus is so variable, the possibility of aplasia, meaning it just never developed, either on one side or both, is actually quite common.
It might just not be there.
Exactly. And attempting to surgically enter a frontal sinus that doesn't exist is incredibly dangerous. You risk immediate penetration into the anterior cranial fossa, into the brain cavity. Therefore, getting a preoperative high-resolution CT scan is absolutely mandatory before any planned frontal sinus surgery. You must confirm its presence, its size, and its drainage pathway before you even think about operating there. #tag B clinical anatomy and preoperative imaging strategy.
Let's talk about the sinus groups again. You've got the maxillary, frontal, sphenoidal sinuses, and then the ethmoids. Remind us why the ethmoids are considered so much more complex.
The maxillary, frontal, and sphenoid sinuses are generally thought of as larger, single, though sometimes septated, air-filled cavities, relatively straightforward spaces.
Okay.
The ethmoids, however, are totally different. They're not a single sinus. They are a complex, three-dimensional labyrinth, like a honeycomb, made up of numerous small, interconnected air cells. These cells are separated by incredibly thin, fragile, bony partitions called lamellae.
Honeycomb of tiny cells.
Exactly. And these ethmoid cells aren't static. They have a tendency to pneumatize, to expand into adjacent areas or bones. This creates important named cells like the Agarnossi cell anteriorly or the Onodi cell posteriorly, which we'll discuss later. This inherent complexity and variability make navigating the ethmoids surgically very challenging.
And that brings us back to the core challenge for the surgeon, taking those flat CT images and building a safe 3D map in their head.
That really is the cornerstone of safe and effective FESS. The surgeon looks at the CT scan in 3 planes: coronal front view, axial top-down view, and sagittal side view, and has to mentally synthesize these 2D slices into a reliable 3-dimensional model of that patient's specific anatomy.
Why is that mental model so critical?
Because that internal 3D map is the only real defense against inadvertently damaging the critical structures that surround the sinuses, namely the orbit, containing the eye and its muscles sitting laterally, and the anterior cranial fossa containing the brain sitting superiorly. One wrong move based on a misinterpreted 2D image can lead to disaster.
So, preoperative CT is non-negotiable, not just for seeing the disease, but specifically for spotting these high-risk anatomical variations. You mentioned the mnemonic CLOSE earlier. Can you walk us through what each letter represents in that pre-surgical check?
Yes. CLOSE is a fantastic mnemonic for remembering the critical anatomical danger points to actively look for on every preoperative CT scan. It's all about risk mitigation.
Okay, C.
C stands for the cribriform plate, and relatedly, the height or depth of the olfactory fossa, which determines the length and vulnerability of the lateral lamella. This is assessing the risk of causing a CSF leak from the skull base.
Oh.
L is for the lamina papyracea, checking the integrity of this thin bone separating the ethmoids from the orbit. Is it intact? Is it dehiscent? Missing? Is orbital fat bulging in? Assessing the risk to the eye.
Oh.
O is for Onodi cell. looking specifically for this posterior ethmoid cell variation that wraps around the sphenoid and brings the optic nerve and carotid artery into dangerous proximity with the ethmoid sinus. S is for the sphenoid sinus walls, specifically assessing the thickness of the bone overlying the optic nerve and the carotid artery in the lateral sphenoid wall. Are they well covered, or is the bone dangerously thin or even dehiscent?
At E.
E is for the ethmoidal arteries, particularly the anterior ethmoidal artery, identifying its course as it runs across the ethmoid roof. Is it running below the skull base? Is it in a bony canal or exposed? Assessing the risk of causing that dangerous retractable bleed.
So close cribriform lateral lamella, lamina, papyracea, on-odicell, sphenoid walls, ethmoidal arteries. That's the pre-flight check.
That's the essential pre-flight check. Going through each point systematically on the CT helps the surgeon anticipate and hopefully avoid injury to these critical structures. ## to mute critical anatomical hazards and variations, focusing on the orbit and brain.
Let's dive into those close points in more detail. Starting laterally with the orbit's main defense, the lamina papyracea. Describe its risk profile again.
Okay, the lamina papyracea. The name literally means paper-thin bone, and that's pretty accurate. It's the extremely thin medial wall of the orbit, separating the orbital contents from the ethmoid air cells.
Paper thin. So easily broken.
Very easily damaged, either by trauma or by surgical instruments if you're not careful. But the biggest inherent danger is dehiscence.
Meaning a gap.
Yes, a natural gap or absence of the bone. This can be congenital, someone's just born with a hole there, or it can be acquired from previous trauma or surgery. If there's a dehiscence, the orbital periosteum, the lining, and orbital fat can actually bulge or herniate into the ethmoid sinus.
So the orbit's contents are exposed.
Effectively, yes. If a surgeon doesn't spot that dehiscence on the pre-op CT and starts removing what they think is diseased tissue or polyp, they could easily grab and pull on orbital fat, or worse, injure an extraocular muscle or even penetrate the globe itself. Identifying dehiscence is critical for avoiding direct orbital injury.
Okay, moving superiorly now towards the brain. The risk area is the cribriform niche and the lateral lamella. The danger here is a CSF leak, right? Cerebrospinal fluid rhinorrhea.
Exactly. The cribriform plate is the very thin, perforated bone at the highest, most medial part of the nasal cavity roof. It's where the olfactory nerves pass through from the brain to the nasal mucosa for sense of smell. Lateral to the cribriform plate is the roof of the ethmoid sinus proper, called the fovea ethmoidalis.
Right.
The bone that connects the slightly lower cribriform plate up to the higher fovea ethmoidalis is called the lateral lamella of the cribriform plate. And the risk factor here is how deep that olfactory fossa or cribriform niche is.
The depth matters. How so?
Yes. We use a classification, a Keras classification, type 1 through 3, to describe this depth. Keras type 1 is shallow, meaning the lateral lamella is short and relatively thick. Keras type 3 is deep, meaning there's a big vertical drop from the ethmoid roof down to the cribriform plate.
And deep is dangerous.
Very dangerous. In a deep Keras type 3 fossa, the lateral lamella becomes very long, vertically oriented, and incredibly thin and fragile. It's extremely easy to fracture this thin bone during ethmoid surgery, especially when removing partitions near the skull base.
Fracturing, it means.
Fracturing the lateral lamella often tears the underlying dura mater, the lining of the brain, creating an immediate CSF leak. Brain fluid starts dripping into the nose. This requires prompt recognition and surgical repair to prevent complications like meningitis. So, identifying a deep olfactory fossa, Keras III, is a major warning sign.
Okay, lateral lamella depth is key. Now for that specific anatomical variant you mentioned, the anodicell, also called a sphenoethmoidal cell, why is this variation so notorious?
The anodicell is a classic example of how ethmoid pneumatization can drastically alter surgical anatomy and risk. It's defined as a posterior ethmoidal air cell that has pneumatized unusually far back and high up, posterior superiorly.
It grows where it shouldn't.
Essentially, yes. It grows lateral and superior to the sphenoid sinus, sometimes partially or even completely surrounding it. The critical, potentially catastrophic consequence of this misplaced ethmoid cell is its relationship to the optic nerve and the internal carotid artery.
How does it affect them?
Normally, the optic nerve and carotid artery run along the lateral wall of the sphenoid sinus, usually protected by a relatively thick bone. But when an anodicell is present, these structures can end up lying right against the wall of this posterior ethmoid cell instead.
So they're bordered by ethmoid bone, not sphenoid bone.
Correct. And the bony walls of ethmoid cells are typically much thinner and more fragile than the sphenoid walls. Furthermore, the anodicel might have indentations caused by the optic nerve or carotid artery running across it.
What's the surgical danger?
The danger is that a surgeon, intending to open the sphenoid sinus, might mistakenly enter the anodicel first. Thinking they're in the sphenoid, they might dissect laterally, directly injuring the optic nerve or carotid artery, which are unexpectedly located right there, separated only by paper-thin ethmoid bone. Identifying an anodicel preoperatively changes the entire surgical approach to the sphenoid.
A crucial variation to spot. And even if there's no anodicel, the sphenoid sinus itself has inherent risks concerning those same structures, the optic nerve and carotid artery.
That's also correct. Even with normal anatoma, the bone overlying the optic nerve and the internal carotid artery where they run along the lateral or superior lateral wall of the sphenoid sinus can be naturally dehiscent.
Dehiscent, again, meaning missing.
Yes, naturally absent or extremely thin. Studies show bony dehiscence over the optic nerve occurs in perhaps 4–8% of people, and over the carotid artery maybe even more, up to 20% in some series. In these cases, the nerve sheath or the artery wall is basically covered only by the sinus mucosa.
So no bony protection at all.
Potentially none. This means any instrumentation or manipulation, even just suctioning, against that lateral sphenoid wall carries an immediate, extremely high risk of causing blindness or catastrophic carotid artery hemorrhage if one of these structures is dehiscent and exposed. Preoperative CT assessment of sphenoid wall integrity is vital.
Okay, having mapped out the major hazards, let's talk about the functional goal of most sinus surgery. Dealing with the ostiomeatal complex, OMC. Defined SDS again and its primary objective here.
Right, FDS, functional endoscopic sinus surgery. The core philosophy behind FDS isn't just to scrape out diseased tissue or pus. The primary objective is to restore the natural physiological function of the sinuses, their drainage and ventilation.
How is that achieved?
It's achieved by targeting the ostiomeatal complex, OMC. This is the critical drainage area in the middle, made as the space under the middle turbinate, where the frontal, anterior, ethmoid, and maxillary sinuses all drain. The goal of FES is to surgically enlarge the natural openings, ostia, of these sinuses within the OMC.
Why enlarge the openings?
By enlarging the ostia, you improve mucociliary clearance, the natural sweeping action that removes mucus, you allow trapped secretions to drain out, and you allow air to ventilate the sinuses properly. Critically, it also allows topical medications, like nasal steroid sprays, to actually reach the diseased sinus lining where they can work effectively. It's about restoring physiology.
Let's trace the surgical path, starting with the maxillary sinus. Where exactly is its natural opening and what normally hides it?
The natural ostium of the maxillary sinus is rather inconveniently located quite high up on its medial wall, the wall facing the nasal cavity. It doesn't drain downwards by gravity easily.
Very high up.
And this ostium doesn't open directly into the main nasal cavity. It opens first into a narrow channel called the ethmoidal infundibulum. This infundibulum then leads into the middle meatus through an opening called the hiatus semilunaris. And crucially, this whole drainage pathway, the infundibulum and the natural ostium, is normally hidden from view by a delicate, sickle-shaped flap of bone called the uncinate process.
Hidden by the uncinate process. So dealing with the uncinate is the first step to get to the maxillary sinus.
Exactly. Uncinectomy, the surgical removal of the uncinate process, is typically the very first step in FESS involving the maxillary sinus. Removing the uncinate opens up that drainage pathway, unroofs the ethmoidal infundibulum, and directly exposes the natural maxillary ostium so it can be inspected and, if necessary, enlarged.
You mentioned a specific technique for uncinectomy to reduce orbital risk.
Yes, many surgeons prefer using retrograde dissection. This means starting the removal from the back edge, posterior free margin, of the uncinate and working forwards.
Back to front. Why?
Because pulling the uncinate medially away from the orbit as you dissect backwards is generally safer. If you start anteriorly and dissect backwards, there's a slightly higher theoretical risk of inadvertently pushing instruments laterally through the uncinate and into the lamina papyracea, potentially injuring the orbit. Retrograde dissection aims to minimize that risk.
Makes sense. And what about accessory ostia? You mentioned needing to connect them.
Right. Sometimes there are additional separate openings from the maxillary sinus into the nose, usually located behind the natural ostium in an area called the posterior fontanelle. These are accessory ostia. If these are present and are not surgically connected to the main enlarged natural ostium during the maxillary antrostomy,
Yes.
you can get a phenomenon called recirculation. Mucus gets cleared out of the natural ostium by cilia, travels around the nasal cavity, and then gets swept back into the sinus through the accessory ostium. It creates a continuous loop of mucus flow, defeating the purpose of the surgery.
Ah, so you have to join them into one big opening.
Exactly. Any significant accessory ostium must be incorporated into the final maxillary antrostomy opening to prevent that recirculation cycle and ensure proper drainage.
Okay, uncinate removed, maxillary ostium addressed. The surgeon then typically moves into the ethmoid labyrinth itself. How do they know when they've passed from the anterior ethmoid cells into the posterior ones? What's the landmark?
After the uncinectomy, the next step is often opening the ethmoid bulla that's usually the largest and most constant anterior ethmoid cell, sitting just behind the uncinate. Once the bulla is opened, the surgeon starts removing the thin, bony partitions between the other anterior ethmoid cells.
Clearing out the front part of the honeycomb.
Right. The key anatomical landmark that separates the anterior ethmoid cell system from the posterior ethmoid cell system is the basal lamella of the middle turbinate, sometimes called the ground lamella.
Basal lamella, what is it exactly?
It's essentially the bony plate where the middle turbinate attaches laterally to the lamina papyracea and sometimes superiorly to the skull base. It runs in a complex, often oblique plane. Perforating this basal lamella signifies entry into the posterior ethmoid compartment.
So punching through that wall gets you into the back cells.
Correct. Recognizing the basal lamella is crucial for systematic ethmoidectomy. The anterior and posterior ethmoids have different embryological origins and sometimes different drainage pathways and nerve blood supply. So knowing which side of the basal lamella you're on is important for orientation and complete dissection. Its position can be quite variable, which adds to the challenge.
Okay, basal lamella is the divider. Now, moving upwards towards the frontal sinus drainage pathway. What's the typical strategy in FSFs to open that up?
The frontal sinus drains down into the middle mediatus via a complex and variable channel called the frontal recess or nasofrontal duct. This pathway is often narrowed or obstructed by anterior ethmoid cells that pneumatize into that area.
So ethmoid cells block the drain.
Often, yes. The most consistent cell involved here is the Agarnase cell. This is typically the most anterior ethmoid cell located just in front of and slightly above the attachment of the middle turbinate anterior to the uncinate process.
Agarnase. And what's the maneuver?
The standard initial maneuver to open the frontal sinus drainage pathway is to identify the Agarnase cell and surgically remove its roof. This is sometimes colorfully referred to as uncapping the egg.
Uncapping the egg, I like that.
By removing the top of the Agarnase cell, you often directly expose the floor and the opening of the frontal recess or the frontal sinus ostium itself. In many cases, just uncapping the Agarnase is sufficient to establish good drainage from the frontal sinus. If the obstruction is more complex, involving other cells like supraorbital ethmoid cells, then a more extensive dissection of the frontal recess is needed.
Got it. And finally, the deepest one, accessing the sphenoid sinus. What's considered the safest way in?
The safest and generally preferred approach to the sphenoid sinus is via its natural ostium. This opening is typically located in the sphenoethmoidal recess, which is a small space high up and posteriorly, medial to the superior turbinate, or sometimes the middle turbinate if the superior is small or absent.
Find the natural door first.
Yes. The surgeon identifies the superior turbinate attachment, and the ostium is usually found just medial or posterior medial to that. It can often be palpated with an instrument first, then visualized and carefully enlarged.
Any specific cautions when enlarging that sphenoid ostium?
Absolutely. When enlarging the ostium, instruments should generally be directed laterally and slightly inferiorly, away from the skull base superiorly and the septum medially. You have to be extremely careful medially and inferiorly because the posterior septal branch of the sphenopalatine artery often runs right across the anterior face of the sphenoid near the ostium. Aggressive enlargement medially can easily tear this artery, causing significant bleeding right at the start of the sphenoidotomy. Caution is key. ##E. Advanced surgical tips and anatomical hazards. Professional expertise.
We're getting into the real pro-level details now. To operate safely and effectively at this level, surgeons need specific strategies. Let's talk tools first. Does the choice of endoscope angle matter? You mentioned 0-degree and 30-degree scopes.
It matters hugely. For basic visualization, looking straight ahead, clearing out simple polyps, a 0-degree rigid endoscope might be sufficient, especially for less experienced surgeons.
Okay, the straight scope.
But for truly comprehensive and safe sinus surgery, particularly FESS, aiming for physiological restoration, the 30-degree angled scope is absolutely essential.
Why the 30-degree? What does it let you do?
The 30-degree scope allows you to look around corners. You can angle it upwards to properly visualize the natural maxillary ostium high on the medial wall after the uncinectomy. You can look superiorly and anteriorly into the frontal recess to ensure it's fully opened and clear. You can look laterally into the far recesses of the ethmoids.
These things the 0-degree misses.
Precisely. Without the angled view, you're operating partially blind in critical areas. You might miss residual disease, fail to fully open a drainage pathway, or worse, inadvertently damage a structure you couldn't see clearly with the 0-degree scope. Elite FESS requires mastery of the 30-degree scope, and sometimes even 45 degrees or 70-degree scopes for specific situations like the sphenoid or frontal sinuses.
Okay, angled scopes are key. Now, when dissecting along the skull base, that ultimate upper boundary, you mentioned a safety principle based on its natural slope. Can you explain that again?
Yes, this is a fundamental safety rule. The skull base, the roof of the sinuses, isn't flat. It generally slopes downwards as you move from anterior, near the frontal sinus, to posterior, towards the sphenoid sinus.
Slopes down towards the...
Right. Therefore, the cardinal safety rule when dissecting along the skull base, for example, during ethmoidectomy, is to work from back to front.
Back to front. Why is that safer?
By starting your dissection posteriorly, say near the sphenoid face or posterior ethmoids where the skull base is lower, and systematically clearing the cells moving forwards towards the frontal recess, your instruments are always moving away from the danger zone. The danger zone is the deeper, more fragile anterior skull base, especially the cribriform plate area, and the thin lateral lamella in the olfactory fossa, which is higher up.
So moving forwards keeps you out of that deeper anterior depth.
Exactly. If you work front to back along the skull base, you risk inadvertently pushing instruments downwards into that deeper anterior fossa, increasing the risk of CSF leak or intracranial injury. Back to front dissection along the roof is the safer, more controlled direction.
That makes sense. But what if the usual landmarks, like the middle turbinate, are gone or obscured by massive disease or previous surgery? How does an experienced surgeon stay oriented then?
That's a challenging situation, but even in massively diseased or revised sinuses, certain robust landmarks usually remain remarkably constant and identifiable.
That's just...
Structures like the floor of the orbit laterally, you can almost always feel or see the denser bone of the orbital floor. The choana posteriorly, the distinct posterior opening of the nasal cavity into the nasopharynx, and the hard, bony anterior face of the sphenoid sinus deep posteriorly.
So these tend to survive even extensive disease.
They're usually preserved. These become the surgeon's reliable anchor points. By identifying these constant structures, even if the turbinates are gone, the surgeon can reestablish their three-dimensional orientation, locate the approximate level of the skull base relative to these landmarks, and still apply principles like the back-to-front dissection along the roof. Experience allows you to navigate using these secondary, more robust landmarks.
We've touched on image guidance systems, the computer navigation. You stressed they're only an augmentation. Can you reiterate the critical caveat about relying on them?
Yes, it's worth repeating because over-reliance is a trap. Image guidance systems, which track instrument position relative to the patient's CT scan, are incredibly valuable tools, especially for complex cases, revision surgery, distorted anatomy, or operating near the skull base or orbit.
They help navigate.
They do, but they must never be followed blindly. They are aids, not infallible guides. There are inherent limitations. Registration accuracy can drift slightly during the procedure. Soft tissue swelling can change the landscape compared to the pre-op scan. The instrument tip shown on screen might not be exactly where the physical tip is.
So don't trust the screen over your eyes.
Never. The surgeon's primary guide must always be their thorough, internalized knowledge of the anatomy, what they are seeing directly through the endoscope, and the tactile feedback from their instruments. Image guidance should only confirm what the surgeon already suspects based on their anatomical knowledge. If the guidance screen disagrees with your direct visualization or anatomical understanding, you trust your understanding, recalibrate, or reassess. Blindly following the navigation into a danger zone because the screen says it's okay is how catastrophic injuries happen. It supplements, it doesn't replace, anatomical mastery.
Understood. Finally, let's revisit the sphenoid sinus and detail that specific hazard you called the carotid artery trap.
This is a really specific and dangerous trap within the sphenoid sinus. The sphenoid often isn't just one big cavity. It frequently contains bony septations, thin internal walls, dividing it into compartments.
Okay, internal walls.
Now, these septations don't always run neatly down the middle. Very often, a sphenoid septum will attach laterally, directly onto the bony bulge or canal that covers the internal carotid artery as it courses through the sinus wall.
The septum inserts right onto the carotid's bony covering.
Exactly, or sometimes onto the bone covering the optic nerve. The trap is this. If a surgeon tries to remove one of these laterally inserting septations by simply grabbing it with forceps and forcefully avulsing it, pulling it away,
Yes. What
they
happened?
risk fracturing or pulling away the very bone that the septum is attached to, which might be the thin bony covering of the carotid artery itself. This can lead to immediate, massive, and potentially fatal carotid hemorrhage within the sinus.
So you absolutely cannot just pull those septations off.
Absolutely not. Laterally inserting sphenoid septations must be handled with extreme care. They should be carefully taken down using drills or cutting instruments right at their base, bit by bit, never forcefully avulsed. Identifying these septations on the CT scan and respecting their attachments is critical to avoiding this devastating complication. And again, preserving landmarks like the middle turbinate helps orient future surgeons if revision is needed, making even these deep areas safer to navigate. #TAG conclusion and final thought.
Wow. Okay, this has been an incredibly dense, detailed mapping session. We've journeyed from the outside in, covering the external nasal supports, defining the scroll area, the absolute importance of that keystone architecture. We walked through the mechanics of septorhinoplasty, the function of spreader grafts, and the stark consequences, like saddle nose, of exceeding structural limits.
And the vascular hazards?
Yes, the vascular hazard. Understanding the dual supply, the critical danger of the anterior ethmoidal artery retracting into the orbit because it comes off the internal carotid, and the surprising risk of vasoconstrictor toxicity. Then we moved into the sinuses.
Mastering the terminology there, crista ethmoidalis for the SPA, lamina papyracea vulnerability, the lateral lamella and CSF risk, the deceptiveness of the Onodi cell, and the strategic importance of maneuvers like uncapping the egg for the frontal sinus.
Right, and we consistently anchored all these anatomical details back to the high-stakes reality of operating inches, sometimes millimeters away from the eye and the brain. The variable depth of the olfactory fossa, the potential for natural dehiscence over the optic nerve or carotid in the sphenoid, it's sobering.
It really is. The margin for error, as we said at the start, is vanishingly small in many areas. This isn't just about knowing names, it's about understanding the 3D relationships and the implications of variations.
So connecting all these dots, what does mastering this level of anatomical detail truly mean for the elite professional? How does it translate beyond just avoiding specific complications?
I think it means fundamentally understanding the system's inherent vulnerabilities. Realizing that the body's design puts branches of the internal carotid artery, the brain's primary supply, right into the roof of the nasal cavity, directly in the surgical field. When you internalize the frequency of risks like AEA retraction or the potential for a simple injection to compromise vision, you have to look beyond just surgical technique.
How so?
You recognize that a seemingly localized nasal issue, like chronic sinusitis or a bad nosebleed, exists within a system where intervention can rapidly threaten sight or cerebral circulation. The vulnerability isn't just the structure you're touching, it's the network it's connected to. Mastery means respecting that entire interconnected system.
That perspective sets up our final, provocative thought perfectly. For you, the listener, aiming to understand this at the deepest level, given how easily vascular complications can arise, specifically because the internal carotid directly supplies parts of the nasal roof, and acknowledging the extreme time sensitivity, especially for saving vision after something like an AEA bleed, what preventative steps, going beyond just the surgeon's individual skill, absolutely must be integrated into the entire perioperative process?
Yeah, that's the critical question. If the anatomical margin is millimeters and the consequence of error is potentially blindness or stroke, surgical skill alone isn't enough. The system around the surgery has to be equally precise. So we have to ask, what specific team protocols, what logistical fail-safes need to be mandatory?
Things like
Immediate post-operative neurological and visual acuity checks, clearly defined thresholds and pathways for initiating emergency orbital decompression, guaranteed rapid access to CT or MRI if needed, maybe even specific communication protocols between the surgical team, anesthesia, and recovery room staff focused on these known risks. The deep knowledge of the anatomy forces us, or should force us, to build system safety nets that are as meticulous and unforgiving as the anatomy itself. That's the ultimate translation of anatomical mastery into patient safety.